Mediastinal location are very challenging, and it is very important to pay attention to the critical organs, specifically that most of the time when we give radiation, we have to pay attention to the patient's age, to the benefit that we're giving, and to the ability of chemotherapy alone to take care of these patients. So this is a 28-year-old female presented with a right neck mass and shortness of breath. The neck biopsy confirmed the diagnosis of Hodgkin lymphoma. The PET scan showed the disease in the bilateral neck, going down to the mediastinum, more on the right side of the heart than the left. And the case was best classified as early unfavorable as per the German Hodgkin study criteria number 11. And she received 4 cycles of ABVD, did achieve a complete remission by PET scan criteria, and now presenting for consolidation radiation therapy. Although the dose mentioned here is 30.6, but then quite often we use 30 gray since that fits more with the HD11 doses. This is how we simulate these patients. We pay attention to many details, and I will start from the head going down. As you can see, because the patient is on an inclined board, and that inclined board is meant to decrease the or move the breasts away from the level of the mediastinum down and outward. And because you want to make sure not to collide with the table whenever the gantry goes posteriorly, then you make sure, one, to put the isocenter very posterior, and second, to put a face mask on that patient to move their mandible away from the entrance of the beam that is going to be closer to the mandible since the patient is on an inclined board. So to sum it up, you put the inclined board to benefit the breasts, but then there are implications of having the inclined board. One, that the mandible becomes closer to the entrance of the AP beam, and two, the gantry might collide with the posterior beam. Therefore, to mitigate that, you put a mask to elevate the mandible and hyperextend the neck, and you put the isocenter as posterior as possible, not to collide with the table. We also have a VAC lock that we consider it as more of a lymphoma VAC lock, and it ensures that the patient is in a stable position, the neck in a stable reproducible position, the shoulders, the elbows, all the way down to the bottom part of the patient. And because the patient is on an inclined board, then it is helpful if we put a thigh stopper to prevent them from sliding down. You can see the goggles here, which are meant for a feedback if you're using an RPM system for the deep inspiration breath hold. These are very important because the patient then can ensure that the breath hold is done on daily basis in a reproducible fashion. As opposed to when we're gating to chase a tumor in lymphoma, the idea is to expand the lung on daily basis to the same volume, because that will mean that the heart is moved to the same position, the mediastinum is thinned to the same level, and the only way to achieve that is by a feedback that the patient will give through looking at the goggle whenever they take a deep breath, rather than just coaching them with an audio, because then the breath hold level and the volume of the lung would not be reproducible from day to day. These are axial images where we've used the pre-chemo CT and the pre-chemo PET scan. And again, it is important and helpful to fuse these studies, but at the same time, it could be challenging to figure out how to correlate the difference in the arm position when we do the PET scan arms up, and if we end up doing the CT simulation arms down. Specifically in a female, we would like the simulation to be done arms down, not to lift the breast up into the mediastinal field. So that will help avoiding the breast further and moving them away from the radiation field. So as you can see here, we pay attention to all the critical organs starting from the thyroid, but the CTV chases the fat in between the muscles and does not include the muscles. And if you compare it to the pre-chemo PET scan, it looks like the mass that you see here has shrunk, and we did not obviously include it all as if the CTV is almost half the volume of what was apparent on the pre-chemo volume. But that is intentional because lymphoma does not invade into the neighboring structures like how you see in adenocarcinoma. Therefore, when it responds to chemo, it collapses like a balloon. And for that reason, you end up with a CTV that looks as if it is chasing really the fat in between the vessels and the muscles. Another example of what we're talking about, when you do your CTV, you remove from it the air, the trachea, the lung, the bone, and the muscles. When you go down to the level of the mediastinum, you're doing the same thing. You try to avoid the great vessels because they were never involved, even if the mass was next to it. You try to avoid the manubrium and also the lung. And it becomes very obvious what we're doing when you compare the pre-chemo CT here. And also you can see the effect of the breath hold. The mediastinum is way wider without the breath hold versus with the breath hold, where you can see that the mediastinum has gotten thinner. Going down to the heart, this is when you can really see the difference of many things. One, starting with the breath hold, as you can see here, at the same level of the heart with the breath hold, that's how much of the mediastinum is left, that small triangle versus this big triangle without the breath hold. You can also see the benefit of the inclined board. On the inclined board, you can see the breasts with their glandular tissue in here just appearing or just started to appear. While in the pre-chemo CT, you can see that we are way below that same level on the same cross-section for the heart. So you can see how much glandular tissue you see in the heart and the breast here compared to the one on the CT SIM. This is a coronal section showing how the CTV ended up being chasing all the areas where the nodes used to sit, is like the site or the origin of these lymph nodes, without including neither the bone, nor the muscles, nor the lungs, or the heart. And the same thing when you look here at where the mass used to be. Quite often these masses, because they're bulky, they actually, when they respond to the chemotherapy, they shrink up or they move up. So there is no point of chasing them all the way down with the heart, because they never actually invade into the heart. This is another showcase for the benefit of breath hold. You could see here how the heart is standing up right now, as opposed to laying down on the diaphragm. Therefore, you move the left ventricle and the LAD, which is the most important coronary, away from your treatment field. The butterfly IMRT is meant to use anteroposterior fields only and never lateral fields, because heterogeneity and a comprehensive targeting of the CTV, PTV does not take priority over the critical organs. Therefore, even if we end up with some sort of a heterogeneity or some sort of underdosing of certain areas, that should be okay in lymphoma. And the most important thing is to really avoid the critical organs. This is a display of the isodose lines showing you the combined benefit of the butterfly technique, the inclined board, and the deep inspiration breath hold. When we first looked at the PET scan, you probably felt that many of the planning benefits were not achievable. But as you can see here, the lung is off of the V5 in the majority of it. The LAD is off of the V5 too. Same thing with the left ventricle is completely off the dose. And as you can see here, because we did not use any lateral beams, the breasts are off even the lower dose. So then when you look at the DVH, you find all the organs that you're interested in comes on the left side of your DVH. Part of the LAD, which is the beginning of it, might get into some high dose at the V5 and the V10, but still we have to remember that the 5 gray and 10 gray are being delivered over 3 weeks. So on daily basis, you're getting less than 1 gray to the LAD, and that will prevent it from having the same bad outcome that has been reported in the literature at the time where we use mental field or cobalt. So then the take-home message is that when treating mediastinal locations and to be able to best avoid excess dose to the organs at risk, namely the heart and its substructures, breasts in females, and lungs, the following techniques can achieve that goal. 1, contouring the critical organs, including the heart substructures. 2, IMRT using anterior-posterior beams only, like the butterfly. 3, breath hold to move the heart downward, increases the lungs volume and slim the mediastinum. 4, use an inclined board to move the breasts down and outward and away from the mediastinum.